Hi, good evening, everybody. I'm Dr. Betty Teh. I'm a consultant cardiologist and also the founder of Beating Hearts. And once again, we have another webinar.
Consultant cardiologist and also the
Okay. I'd like to invite, I'm very, very pleased that Dato Dr Amar Singh has agreed to give us and yet another talk, take his time off from leisure and pleasure to give us a talk on pediatric x-rays. And the response has been really, really tremendous this time around. We have had about 700 registrants and unfortunately, Zoom can only allow 100. So we are actually live on Facebook on Beating Hearts, okay, the page. So maybe without further ado, we'd like to invite Dr. Amar Singh.
Thanks, Betty. And basically, Betty, I'm busy more with NGOs and supporting people during this COVID epidemic. And I take my leisure breaks to keep alive, which I think we all need to do. Huh? Now, everyone who's here or on Facebook, please call me Amar and bin the rest. Sorry, I'm just closing something here. And now this is going to be a different kind of session in the sense that we're going to see lots of X-rays, and the best way to do is ask questions ongoing rather than at the end. I can handle questions at the end, but I believe questions ongoing are great. Betty's going to monitor Facebook and field questions from there, and those who are in the Zoom, you can unmute quickly and just ask a verbal question, right? Or you can post a question in a chat group and Betty can look at that. I won't have a chance to look at the chat group.
Yeah.
So let me share my screen first and go. Yep. Betty, can see the screen?
Yes.
Okay, good. This is an X-ray of shells. I find X-rays a very beautiful modality, and just show up things quite well. And as a pediatrician, I've always valued what X-rays do for us. I must say at this point that I suspect in the future, all of us will carry an ultrasound in our pocket attached to our handphone. And that will be another modality that we must, investigate. I've been doing ultrasounds for many years on my own. I'm not a radiologist, but I find ultrasound's another wonderful modality. But let's do X-rays. Huh? Now, I have an important notice here that the confidentiality of children whose X-rays are shown here is maintained. We're not showing any of their names or giving any personal details. I've also taken X-rays from various sources, some from my own clinical work, some from online sources and databases. The copyright of the image remains with the original source, okay? And they're used here only for teaching purposes and not for any financial gain. I'm going to focus a lot on younger children because they're harder to read. Older children are more like adults in some way. And here, for example, and I'm going to show you about 100 X-rays as we go through. Here's a neonate, which is an AP supine portable, and that makes a whole different ball game compared to an adult who gets an erect PA. For example, here is an adolescent who's got an erect PA, and that makes the X-ray much easier to read than an AP supine portable. The portable gives all sorts of problems. In addition, anybody who's seen an neonatal X-ray or a young child X-ray, especially who's ill, will find all sorts of things all over the place, wires which cause problems. So when you're looking at X-ray, think of these things here on the right. Huh? Think of the positioning, which will change to how the X-ray is viewed. Think of the quality, which means basically the exposure, the penetration. And I find neonatal X-rays are usually over-penetrated by most of our radiographers. The rotation, which can be done looking at the clavicles. For example, if you look at this teenage X-ray, you can see the clavicles are not even at the top there. So obviously there's some degree of rotation here. I find most neonatal X-rays are rotated. This is an unusual one where there's hardly any rotation. Then think of inspiration. Anterior ribs about 6, posterior ribs 8 to 9. Most people count posterior ribs. That gives you an idea of whether it's adequately under or over inspiration. And then there are tubes, markers, and artifacts, which is a nuisance sometimes, but the tubes we need to know because we want to know where they've gone. Think when you're looking at X-ray, the heart, the lungs, the airway, soft tissue, bones, abdomen, GIT. Basically, I look at everything. Even though they may give me a chest X-ray, I look at the abdomen, I look at the bones, because you'd be surprised what you see in X-ray and may give you information. So adolescent here, as I said, notice the breast tissue developing, which adds to the looking at it in older girls. Okay. Now we know that different objects have different density. There's air, which is very dark, and metal and bone, which is, you know, very bright. And in between, there's oil and water. Fat and water. Okay. Now you need a system, and this is a system that many people use, the A, B, C, D, E, F. I don't use it, maybe because I've seen so many X-rays, I just look at everything. But I recommend that if you're young, you know, start one area and then work your way through the X-ray. But look widely, as I said. Don't look at just the lungs. Huh? Look widely and use your handphone. I'll talk about straight away. Here's what I mean using a handphone. I find people don't use. In the past, I used a magnifying glass quite a bit. People always used to think I was weird carrying a magnifying glass around. But here's using a neonatal X-ray of the abdomen, and here's taking a picture of it with my handphone and then changing the contrast and brightness with a handphone app. There are plenty of handphone apps. All of you use image apps on your handphone, and notice that now this liver margin is visible and the whole contrast is very different. This child has got a peritoneal air leak. There's a pneumoperitoneum here, but this wasn't so visible on the original X-ray that was done. Okay, so use your handphone increasingly. Take a picture, change the contrast of the X-ray. Of course, make sure that the orientation is right. Be careful when everybody writes left or right on the X-ray, then I don't trust them anymore. I prefer the original marker there and the right date. And the best thing is keep looking, keep asking questions. You know, I was always a pain to my older colleagues, always asking them questions, and I encouraged you to do that as well. And of course, now there are huge online resources as well. If you know the common conditions in units and children, then the whole interpretation becomes easier. The history to me is always critical. Quite often I know the diagnosis before I looked at X-ray, and that's useful for all of us. So for neonates, there's this problem of the thymus, and I'll show some pictures of that, and you need to know some normal variation. But of course, there's cardiomegaly and cardiac abnormalities, there's respiratory distress syndrome, there's meconium aspiration, there's acquired and congenital pneumonias, there's pulmonary hemorrhage, effusions, pneumothorax, and GIT abnormalities. So this is what I'm going to show to you, some of these. For children, and as I said, I'm going to focus largely on the younger children, which is harder. You again need to know, get a history that's useful. Cardiac size, pneumonias, pleural effusions, pneumothorax, foreign bodies, and I put child abuse there. These are things that I commonly see, and I'm going to focus on these issues. I'm not going to show you too much rarities. Now for tubes, a lot of tubes that we're going to see are going to be neonates. And you need to know how the umbilical artery catheter travels. And I'm not going to cover it here right now, except that, you know, that's roughly how it goes. Always got this U shape or this V shape at the bottom there because of the way it travels, okay? And whereas the umbilical venous catheter has less of that U shape, it travels actually more directly up. And we want to sit above the liver. Whereas for the umbilical catheter, we want to sit somewhere up here, which is T4, T6 or T9. We don't want to enter into the vessels which are coming off the aorta there. We don't want to go in the heart, of course. And we don't want to sit down here where the celiac artery and plexus. I saw one umbilical artery catheter sitting here, and he infarcted the entire celiac trunk and caused a massive NEC. So we want to sit somewhere there. And for UVC, you want to sit above the liver. We don't want to perfuse the liver with anything because UVC is often used for higher solute fluids. So this is what it look like on an X-ray. This lateral is rarely done, but it shows you an idea. It shows you the umbilical artery catheter goes down, runs along the spine and goes up, but we won't get that view, okay? So we'll get this kind of view where the umbilical artery catheter goes down, dips up and goes up, okay? And this is the umbilical venous catheter which goes straight up, okay? And on the surface, it goes right across like that. Okay, so the ETT is there. Now, how do we count? We count ribs. Many people count from the top, but I'm a bottom counter because I find that the ribs are easier to see from the bottom. And I count the posterior ribs. So here's one rib here that you can see. So I just count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Oh, so I know this is the 11th rib. The 12th is down here. The 12th rib wasn't very clear to my view. So now I know this is T11, 10, 9, 8, 7, 6, 11, 10, 9, 8, 7, 6, 5, 4. ETT is sitting at T4, not a good location. It should sit preferably a little bit up. T2, T3 is best. T4 is the max because we're really touching the carina. And the UVC and UAC positions are good. All right, so we need this. Notice the NG tube is coming down here as well, and lots of guide wires measuring the heart rate and respiration. So I'm just going to show a few catheters before we jump into making a diagnosis for conditions. Notice here the umbilicus venous catheter, UVC, has gone into the liver. This is a catheter that cannot be used. The UAC is in good position, NG tube there. So this kind of catheter has got to be removed. I can tell you from experience, putting it back again will go back the same track. They have this tendency to do this. Okay. Here's an umbilical artery catheter going all the way up, and umbilical venous catheters also going all the way up. I'm not sure where they are. They've probably gone up quite significantly up, and I wouldn't use that. ETT, a little bit on the high side up there. Okay. Here's an umbilical venous catheter, which is coiled in the liver, again, cannot be used. And umbilical arterial catheter on a very low position. Low positions are accepted. But notice the chest tube here. Notice this chest tube that is in here. Notice at one point, one hole of the chest tube is outside the lung. This chest tube is going to cause, surgical emphysema. Air is going to leak from the lung out to here, and we need to take this chest tube out and put a new, fresh one in if we need that. There's still a small pneumothorax present in this lung here. Okay. And here's an umbilical venous catheter gone up the inferior vena cava, superior vena cava, right atrium, left atrium, foramen ovale, right through, and then into the left ventricle. So it's important to do a check X-ray always for these catheters and see what's happening to them and adjust them accordingly. Now I'm going on to doing the X-rays proper that we talked about. And let's start with the timers for neonates. Usually they are until about 2 to 3 years of life, and often it's this kind of classical sail shape and causes lots of problems for individuals because of its appearance. Here's another timers, smaller this time. Okay, notice all these X-rays are AP, and so the number of ribs, the inspiration is not going to be as good, and it depends when they catch a child, whether he's crying on inspiration or expiration. Okay, so timers. And here's another one. This one almost looks like a mass. If I show this to an adult physician, they probably say this is a mass, but actually this is just a round thymus. And the worst is this kind of a mass. It's actually a thymus. I saw a 3-year-old child like this, 2.5-year-old child like this, who presented with a cough which is prolonged. And so we did the X-ray, and then we saw this thing. Mom was actually a colleague, a physician. And, then we didn't know what to do. We had it reported, and people say this is a mediastinal mass. Have to do something about it. The child was fairly well. Grandma wanted to, kill me because we were planning to put a needle inside to biopsy this. In the end, one very wise radiologist, I posted X-ray to a couple of good friends, and one very wise radiologist said, no, sit on this is the thymus, and we sat on it and it shrunk. So it can be very difficult thymus sometimes.
When does it shrink in time? So
usually it may shrink if you have acute stress. In the neonates in NICU, I find that it shrinks very rapidly over a few days, even a week. But for normal children, it would take by 2 or 3 years before it starts to disappear and no longer be appreciated. Okay, so sometimes the thymus can give us problem, and we need to know that. But generally, this kind of thymus, many of us would have concerns and want to watch it. Okay, thymus can also mimic cardiomegaly. And it depends a lot on the rotation of the X-ray and so on. So this heart is not big. There's a thymus there that's mimicking cardiomegaly. So problems with the thymus that we need to know. So for small babies, always look out for the thymus and get a good feel. And it comes in a variety of forms, so you've got to keep looking to get a good judge of it. Now I'm moving on and considering the heart right now, and all of you can see obviously what's happened here. That's a dextrocardia. Okay, and we see dextrocardia occasionally. Here's another dextrocardia, but notice that the stomach bubble is on this side. So this is dextrocardia with situs inversus, which is a good thing to have, actually, because usually, I'm this cardiologist in the audience, so I've got to be careful. Usually it means there's less cardiac abnormalities. Whereas one like this, where there's dextrocardia with situs solitus, not situs inversus, is bad. This is bad because quite often there is a significant congenital heart, and I find in my experience and also from text that this congenital hearts are usually quite severe congenital hearts. Notice also the X-ray is rotated, the baby's head is on one side.
I know that. Sorry, I know. Yes. I'm a cardiologist, but I don't do peds cardio.
Yes, sure, that's okay. Yeah.
Yeah, this is very interesting to me. Okay, yeah. Go on. Sorry. Yeah.
So differentiate between dextrocardia with situs inversus and dextrocardia with situs solitus, because once you see situs solitus, definitely I'm going to do an echo to look for abnormalities. Okay, this can be an isolated finding, or it could be in a child who's very ill. Here's an enlarged heart. You can see that heart is biggish. The thymic shadow is very, very small there. The mediastinum is very small. Okay. Don't worry about diagnosis for this particular child. But the important thing is to try and measure the cardiothoracic ratio. Now, I don't see anybody really measuring with a ruler. I used to do it when I was younger, then I abandoned because it became obvious to eyeballing it. You look at his heart, you know it's big after seeing enough. And that's what I recommend to you. Sometimes I do use my pen and measure the cardiothoracic ratio. And in a PA view, is accepted at 0.5 maximum, AP is 0.6, 60% of the diameter. Huh? Okay, so that gives you a rough ballpark. Here, of course, is no cardiomegaly in that X-ray. So here's another cardiomegaly. Notice that this one has got a lot of lung markings because there's cardiac failure. It's sort of an egg on side picture, and this is a classical transposition of great arteries, which presents in the first few days of life usually. It can present a little bit later, but usually first few days of life. Okay, so that's a cardiomegaly, cardiac failure, transposition of great arteries. Okay, cardiac failure in children usually doesn't cause liver enlargement, usually cause pulmonary edema. Okay, unlike adults, which you get liver enlargement. Here's another child. Notice the child is born very big, 4+ kilos, cesarean section because of the size, in front of a diabetic mother, probably on insulin, and then develop respiratory embarrassment very early. So this is hypertrophic cardiomyopathy caused by the uncontrolled diabetes in the mother. Huh? So the story was good enough. So once you get this kind of story, you see this kind of X-ray, you know the diagnosis immediately. Of course, an echo would help. Okay. Here's another very big heart. This is a 3-4-year-old child presenting with cardiac failure, probably for some time already. The left ventricle is not functioning very well. You can see some degree of pulmonary edema there, and now on ventilation. And so this is a congenital heart, the kind of X-rays we see of many of our large ventricular septal defects that come our way. Okay, not a good outcome for this child. Often will end up with pulmonary hypertension if not operated early. And here's a globular like a heart, very big one, sometimes can occupy, almost the entire chest. And that's due to viral myocarditis. This is a dilated cardiomyopathy. And if you do an echo, you'll find the heart's not beating very well and contractility is very poor. Okay. So those are some examples of cardiac size and enlargement. Okay. Here's another cardiac problem, but this time notice, look, it's a boot-shaped heart. You see some absence of the aortic arch there as well. And this child presents with cyanosis at about, usually a couple of months in life, 6 months of life. And this is a tetralogy of Fallot's, which presents. Sometimes the aortic arch is on the left side, which is why you may not see it. And the boot-shaped heart is there. Okay. You seldom pick it up at birth. You might if we did echo on every child, but that's very time-consuming. So it usually presents in a couple of months of life with cyanosis. Okay. All right. I'm going on to the lung proper, that was heart. And this is what a normal X-ray for a neonate would look like. Okay. Notice the heart's not that easy to see. The spine is quite easy to see again because of a bit of overpenetration. And that's what the lungs might look like in a slightly, slightly hazy kind of look. I don't like that word, but that's what it looks like there. So this is something you don't see much anymore. It's there all the time, but because we treat it very quickly with surfactant, we don't see hyaline membrane disease anymore. Idiopathic respiratory distress syndrome. But this is what it looks like. This is called ground glass appearance. So this has a bleb there, a black bleb. That's pulmonary interstitial emphysema developing. If that continues for this child on ventilator, you're going to get a pneumothorax developing. Whenever I see those air leaks, I suspect there's going to be a pneumothorax coming my way. Here's a more severe hyaline membrane disease. You can actually see the airway well outlined. It's almost a complete whiteout. Why do they call it ground glass? Because if any of you are older in the audience or play kites like I did when I was young, we used to take our glass and we used to tumbo it with a pounder and smash it up into powder form. And then we use starch and put on our flying kite so that we can break the kite of our friends. Huh? And so that kind of appearance of broken, pounded glass is ground glass, and it looks just like this. Notice again, some blebs of air appearing, interstitial emphysema appearing, indicating X-ray rotated there, ETT a bit on the high side, but probably acceptable. Okay, all right. Some more blebs are hyaline membrane disease. Huh? Now something mimics hyaline membrane. Oh, sorry, by the way, this is before surfactant, after surfactant. And nowadays we give surfactant at birth quite often. So we will just see an X-ray looks like that, where the lungs are already cleared because surfactant has solved the ground glass appearance. Okay, but pre and post surfactant. I think it's very important after surfactant to do a chest X-ray because you might end up with a pneumothorax as well, a air leak. One condition that mimics RDS is GBF sepsis, is congenital pneumonia. If your membrane's been ruptured for some time and there's group B streptococcus in the vagina, babies are breathing in utero, so the line cord will get infected, and the baby's breathing line cord in and out, and so the entire lung will get infected. And so it looks like ground glass appearance. If you've got a premature baby like this, it's almost impossible to differentiate, and the culture is going to take some time to come. Of course, in this baby, platelets were a bit low, so you suspect that that's suggesting a sepsis in this baby. Here's another group B streptococcus pneumonia with looking like hyaline membrane disease, which is why pediatricians quite often, treat premature babies with antibiotics until the cultures come back when they're worried about this sort of situation. All right. So that's group B streptococcus, which mimics hyaline membrane disease or respiratory distress syndrome. Okay. Now, this is meconium aspiration syndrome. This is one of the worst conditions to have as a neonate. This is a condition, which mortality is very high, and usually in big babies, term babies. And, the meconium is aspirated in the lung in different sections. In some sections, it blocks the airway and causes consolidation with some collapse. In other sections, it causes a ball valve effect, and that gives you hyperinflation. So you get this kind of mixed picture. Usually a hyperinflated lung with some patchy consolidation across the place. Here's another nasty MES with consolidation, in different parts of the lung. Okay, poor outcome for this kind of children. Okay, another MES. You can see the gross hyperinflation that we're seeing here right now, and patchy consolidation across the board. I'm moving on to specific pneumonias and stuff. This one I showed before. I showed the pneumonias. You show an upper lobe collapse due to aspiration. You can get aspiration like this as well. And this, which is why we should always prop up babies when we feed them. But some people feed their babies lying down and then they aspirate straight into the upper lobe and cause a collapse consolidation. This one largely consolidation there. Okay.
Just from feeding?
Just from feeding, yes. Okay, here's what a normal aspiration will look like in the baby. It looks like the MES a little bit, but without the stickiness of the meconium. And this will aspirate all over the lung, choke, liquid fluid comes down and aspirate throughout the lung. Okay, this is when the baby is propped up or feeded seating. Okay. Now, here's a baby which has an aspiration, but look at the story. Born 3 kilos, required aspiration of mucus at birth, given oxygen, half an hour later becomes cyanosed. Again, required more aspiration, had lots of mucus. Okay, so what's the diagnosis here, you think? There's no meconium at all. It's clear lico. The term baby is not RDS. Term babies can get RDS, but rare, but it's not an RDS picture. This is an aspiration picture. So this kind of baby, you got to be suspicious. Okay, the first thing I would do is put an NG tube in, and the NG tube will coil like that, and then you know you're dealing with an esophageal atresia. So the saliva was pooling in the esophagus, and then the baby choked and aspirated into the lung. Okay, notice that this coiling here is associated with no gas in the abdomen. So this is esophageal atresia without a fistula, and so it's a complete esophageal atresia.
So an easy diagnosis to make, just by putting the NG tube.
Oh yes, that's right. Yeah, correct. It's not that difficult. Here's another one. You can see the tube is coiled up there. NG tube is coiled up there, but notice there's gas down here. So this is a esophageal atresia with a fistula. Okay, so the fistula is coming from the lungs, and gas is being provided to the abdomen. Okay. Now, sometimes, surgeons are not convinced. I had a baby with a tracheal fistula, but no esophageal atresia. That means the connection was there. And here's the baby. You can see the lungs are there, and that's the gut. There's a fistula there. And I had to do a contrast study to show this, that there is a tracheal fistula to this baby, because this baby will get recurrent aspiration into the lung and get a recurrent pneumonia. Huh?
But if you do a contrast study,
yes, it's messy. It also went into the lungs.
Yeah.
Yes, it is very messy, but we had a tough time persuading our surgeon for this particular baby to, to get the surgery done. So we were forced to do this, and yeah, we had to ventilate the baby afterwards. But already we ventilated the baby for recurrent nasty pneumonias. Huh? Okay.
But
so,
it's
Yeah.
prognosis good after surgery?
Yes, prognosis is good. Not difficult to do this.
Okay.
All right. Now, sometimes you see a whiteout lung in a baby. Okay, I'll come back to more pneumonias later. And when you see the whiteout, you've got to think of a couple of different things. It could be a collapse. If it's a collapse, usually the lung will, the lung on the other side will shift over that side. An effusion, which means the white side will push to the other side. It could be a pneumonia, in which case there may be no movement. A mass, in which case the mass will push the lung on the other side. And of course, cardiomegaly will gain some degree of push. Okay. Notice here that ETT is very low, very, very, very low. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 reps, 12, 11, 10, 9, 8, 7, 6, 5. So it's 5 to 6 there. And so it's gone past into the right main bronchus, blocked off the left one, collapsed entire left lung. Okay. So that's a common reason. Sorry, Betty.
Is it iatrogenic?
This is iatrogenic, yes, correct. Very common cause of collapse of the left lung. Here's another one, ETT gone in too fast, left lung collapse. So keep an eye out for this. One reason to always check ETT position on the chest X-ray. Here's another one, again, ETT gone in, hard to see. Again, this kind of X-ray you want to take on your handphone and change the contrast, and then you'll see the ETT very clearly on your handphone.
What app can you use for that?
Oh, there are tons of apps, you know, Betty. Any app that can change your contrast and your what is this? Your brightness will be sufficient.
So it's
I
not
have
a
3 or 4
medical
apps on my phone that I use. Sorry?
It's not a medical X-ray app, is it?
No, it's not. Any app that can adjust your handphone will be fine. Okay. Now here's a pleural effusion, another reason for a whiteout lung. Okay, and here is in the left lower lobe here. And quite often, if you're doing an erect X-ray, you might see a meniscal sign, but in children, quite often they're lying down. You may not see it so clearly. Here's a bilateral pleural effusion in a small baby. Notice that even this lung here has got effusion. You must think three-dimensionally. We're only seeing two-dimension here. There may be effusion behind the lung, and that's making this lung look, white there. There's a thicker effusion here, but there's an effusion at the back as well. This effusion is more substantial than we can see from the X-ray. Okay. Here's an empyema, looks like an effusion. Heart is pushed to the other side, but this child will look toxic. When you get empyema, I noticed that over the last 30, 40 years, empyemas have reduced. I think if you go to Sabah, you'll still see quite a few empyemas. But in the rest of the country, except in poorer parts of the country, we see less empyemas. Here's another gross empyema pushing the heart on the other side. Needs a chest tube to drain this. Of course, it could be a mass, something to think about as well. Occasionally, rarely it's mass, usually it's an empyema. Most of us actually will get a quick ultrasound and see that it's fluid. Here's a bilateral pleural effusion. It's a hydrops vitalis at birth, okay? And will need bilateral chest tubes to drain this, to salvage the baby. It needs an intubation, of course. It's aggressive therapy. And these days, we can salvage some of our hydrops vitalis depending on the cause of the hydrops. Completely white up. Notice also the soft tissue, where there's edema also of the soft tissue, also some amount of fluid in the abdomen as well. So another reason for whiteout is a very big heart. Looks like there may be an effusion here, but actually just a huge cardiomegaly mimicking an effusion right there. And an ultrasound will help you do this, or a lateral X-ray will help you figure this out. Okay. Here's another reason for whiteout is a pulmonary hemorrhage. Often happens to children very ill on a ventilator, often with a DIC, disseminated vascular coagulation, and then they get a massive pulmonary hemorrhage, poor prognostic sign in anybody on a ventilator. Okay. Now, here's something that people don't think enough about. I'd like to bring to your attention. This is a 3-year-old child who's had a fever for 2 to 3 days, was otherwise well, playing, eating, and then he came in unwell, quite unwell, and his BP was a bit lowish. And notice that he's got a pleural effusion here. We're lucky here that the pleural effusion was visible with a meniscal sign, but sometimes like this, it's just a bit of a whiteout. Notice the contrast in the two lungs is not the same. I've seen far more subtle ones than this. Unfortunately, I didn't keep the X-rays. Okay, and all we just see is a little bit of whiteout. The contrast is not the same. The child is lying down, X-ray is taken, and the fluid is all at the back of the lung. And so what's the diagnosis for this child? This is dengue. Dengue very often has a right pleural effusion, and you've got to be very sharp about that. Huh? Okay, it's fortunate in this era, dengue has moved up to older children, teenagers and young adults with higher mortality there. But when I was working, dengue mortality was primarily in children. I expect at some time the whole symptomology will change And we'll come back to having dengue in small infants and children. And this is one very good sign. When you see a right pleural effusion in a child who is febrile, always think dengue as a possibility. And think just of the contrast in these two lungs, which suggests to you there's effusion which is all at the back. I'm just showing this just for interest. This is how some babies were positioned to get a PA view. Yeah, it looks horrible to me, Betty. I asked my older radiologists in Malaysia, they say they've never seen this, but obviously it's done in some overseas countries in the past by some radiologists who wanted the perfect X-ray, you know. We can tolerate imperfect X-rays for the children's comfort. He doesn't look happy at all. Yeah. I'm moving on to pneumonias proper. And here's a bronchopneumonia, okay, just starting out, okay. And quite often in the past, we had numerous bronchopneumonias, but we got less. Now the bronchopneumonias happen more in immune-compromised children, where we will think of pneumocystis carni, or in children like who in poverty, like orang aslis, where measles will cause a bronchopneumonia like this, okay. So a simple infection might cause a secondary pneumonia in a child who's poor with malnutrition. Okay. This is a lobar pneumonia, upper lobe pneumonia, just developing, has not very much consolidation, no collapse here at all. Okay. I think the horizontal fissure is there. I don't know if you can see it on your screen, not it's bulging just a little bit there. Okay. I know this you can find in the textbook. I'm not going to do it, but I'm going to focus largely on the right upper and right middle lobe pneumonias because those are the two that we see the most, and leave you to think about the others. Okay. And here's an upper lobe pneumonia with a collapsed consolidation. The horizontal fissure has been gone up. It looks very much like that aspiration I showed you earlier. These are often pneumococcal pneumonias. Here's another one, a right upper lobe consolidation. Notice in this time there's hyperinflation as well. When I see this much hyperinflation, I'm a little bit suspicious why we have so much hyperinflation. Is this a viral pneumonia rather than pneumococcal pneumonia causing some damage elsewhere? Or has a foreign body somehow come in and the foreign body has, caused some obstruction with hyperinflation? Just to think about. But right now, this was just an upper lobe consolidation with some collapse and hyperinflation. Here's a middle lobe pneumonia, again, very common for pneumococcal pneumonias there. All right. And of course, if you do a lateral, you will see this kind of view. We don't need the lateral. I'm just showing you what the lateral would look like if anybody did it. Okay. We do laterals for some of our lobar pneumonias when we're trying to see them or we're worried about a mass. Okay. This is a pneumatocele, another kind of pneumonia, usually by staph. You can see these nice round circular things. Here's one with a single cyst there. Okay, and you might think it's just a cyst, but of course it shouldn't present ill. They're septic, and this is staphylococcal pneumonias. Don't put a chest tube in. Okay, don't drain this. Leave it alone. Take some time to disappear. Months sometimes, weeks to months, but don't touch it. Okay, unless it's done this. Multiple pneumatoceles, some over there as well, and there's developed an air leak. Then you have to tap the air leak. Okay, all right. The reason you don't want to tap the single ones or the multiple ones is that they may have a fistula, bronchopleural fistula, and then you end up, having a crisis on your hands and need a thoracic surgeon. Here's multiple pneumatoceles, looks like air leak, but no air leak. There's no air leak here at all, okay? If you're unsure, do a lateral decubitus X-ray, and that might help, or ask your radiology colleagues in ultrasound to help you. Okay. Here's a pneumatoceles which has become infected, had a secondary abscess, and we may have to drain this one because it's become infected. Okay. Now, I'm trying to show more conditions, and this is a premature neonate who suddenly deteriorated. He had a little bit of hyaline membrane disease, and he deteriorated. His SaO2 saturation dropped. Can you see the reason for this? Notice there's a bit of a thymus there. X-rays are fairly central. Stomach bubble there, diaphragms, okay? Reasonable inspiration film. But notice that the texture of this lung and this lung are not the same. And here's adjustment with a handphone app, okay? And you can now see more clearly this black there. And so this is a pneumothorax. The pneumothorax, again, think three-dimensionally, involves the entire lung, anterior and posteriorly. Okay, probably more anterior than posterior because it's probably taken lying down. And so this blackness we see here is the fact that this lung, doesn't have, has got more air outside than inside. Okay, so a pneumothorax, a very subtle pneumothorax. You don't have to drain this one, just watch it. Okay, unless the saturation keeps dropping. Here's a classical pneumothorax, huge one. You can see the lung outline there as well. Notice a chest tube has been put in but non-functional. When a chest tube is put in, I do not expect to see a pneumothorax anymore in children. I expect it to be drained immediately. That's a tension pneumothorax will drain very, very fast before you can even do the chest X-ray, repeat X-ray. So this pneumothorax being there, tension pneumothorax pushing across into the left lung, and with the chest tube, and this chest tube is not functional, needs to be removed, a new one put in. I'm not sure why they put it in like this as well. It's a very funny chest tube. Never put a chest tube in front, put it at the side here. You know, you don't want to ever hit. I've seen someone put a chest tube and hit the nipple of a girl and then lost the breast bud. So try not to put chest tubes in front. They're very hard to secure. Put one here in the 4th or 5th space. Okay. Here's another pneumothorax. Notice that the texture of the two lungs is different. Here's darker here. Notice that we can see the outline of that thymus and the heart there, and almost a diaphragm. So this is a pneumothorax there, maybe larger than you expect. Here's a large pneumothorax, definitely chest drain. Okay, not always easy to compare the two lungs. Beware the bilateral pneumothorax. I've seen a couple of children with bilateral pneumothorax, and at first I thought nothing there, but if you look very carefully, you can see the lung there outlined by this pneumothorax. Okay, of course, these children are very, very ill on a ventilator. I had an X-ray like this, a chart just like this on the first day I worked in pediatrics. Walked into the ward about 7:30, didn't report the ketua jabatan yet because I'd done housemanship in the same department. I went to work before reporting, and this was the child that confronted me. A child like this, you know. And required bilateral chest tubes immediately to rescue. So be careful with the bilateral pneumothorax where the contrast of the two may not be so clear.
Is the previous X-ray, is the abdomen abnormal too?
This one?
No, just not the bilateral.
This one? No, I think a lot of air in the abdomen. That's all.
That's all.
Yeah. Thanks, Betty. I hope more people will ask questions. Okay. Now, here's a 3-year-old child, and the classical story is develop shortness of breath while eating, or it might be choked and coughed while playing with toys, or some that kind of story. And so with that kind of story, the thing that must come into your mind straight away without the X-ray is foreign body, lung, because you're choked while eating or you choke while playing. And it's very important not to buy toys for children which have small parts. Don't at all, you know, until they're much older. And so you can see that there's some shift a little bit, but this side is hyperinflated and darker. The lung markings are not as well outlined as on the left lung. So there is a foreign body in the right lung. Here's another one. You can see the difference. The foreign body comes in, causes a ball valve effect, and so you know, there's air trapping here, and you can see this difference. If you're unsure, try and catch a couple of X-rays, inspiration, expiration, or do a decubitus X-ray. It might help. Okay? Most of us, one X-ray is fine for many of us to see this. Okay? And of course, we need to get our ENT surgeon urgent. This is very urgent. Huh? There's work done showing that the longer you leave a foreign body, the airway may come back, but the perfusion may die. So it's important to remove foreign bodies in lungs early. Okay. As I said, when you're looking at X-ray, think laterally. Here's a child, a 2-3-year-old child who came in to my department, and he had been seen in casualty where he was intubated because they thought he had a pneumonia. Mother's history that he had shortness of breath at home, had a bit of fever, and they did his X-ray and they said pneumonia. They intubated him. Came to my ward, seen by my house officers and MOs and young specialists, all said pneumonia. But the moment I saw this X-ray, I diagnosed something else. I wonder whether you can see. I don't think there's any pneumonia here at all. Okay, it's a very poorly penetrated X-ray. The exposure is, you know, underexposed. But can you see the diagnosis? So you got to look laterally all the time. I say, once you finish this, start looking laterally, and then look at this bony. Ah, there is a callus formation here. That's a callus, and this callus is not new. It's children have developed callus much faster than young children, faster than adults do. And this is about 2-3 weeks old. This is a fracture that's healing, 2-3 weeks old. I looked at the child. He had a cigarette burn on his hand, which was about a couple of days old. I looked at his fundus. He had massive hemorrhage. Did a CT scan. He had a subdural bleed. So this is a child with developed respiratory embarrassment due to intracranial bleed, and he had a massive bleed and is child abuse. So think child abuse as well. You know, 10% of all children get sexual abuse. 25% of all children in Malaysia get physical abuse. So child abuse is very common. It is my differential diagnosis for almost any condition. I always keep it at the back of mind. I'm not paranoid. I just recognize child abuse is so common. I'm always, you know, consider it as a differential when I'm looking at children. So it can present differently. You may do an X-ray and then suddenly spot that, why is this rib a bit like that? Those are actually ribs that have fractured, you know, with some callus formation there. Or he might present a fracture Without a story, we won't know. Unless a child tells us that mommy or daddy has or somebody else has done this, we won't know. This could just be a green stick, sorry, a fall with a fracture radius ulna. But this kind of X-ray of the femur, oh, you won't accept that at all. This is a child abuse fracture. It's very hard to do this kind of fracture. Or this kind of avulsion fractures, if you see them there. Huh? It's one of my habits that all children brought in date, I do a full body X-ray of the child, because you can see child abuse. Brought in date children must be suspected to be abused children at home. So think child abuse, look laterally, and this is the first X-ray that taught me to look laterally all the time. This was in the 1980s when I first saw this one. Okay, think child abuse. Huh? All right. I again want to recommend to you what I said just now about post-mortem X-rays. I do post-mortem X-rays for all children brought in date, but I also do them for children who die suddenly in the department. This was a child who was having an exchange transfusion by one of our young doctors, and then during the exchange transfusion died. There is a mortality of about 1% during exchange transfusion, but I've seen very few in my life, and I've done lots of ETs as a young person. Today, of course, we do very few ETs, thank God. They're not pleasant things to do. But when we did the X-ray, we saw this. This is air trapped in the left ventricle. So what we surmise is that during the putting in of the umbilical catheter, the catheter crossed over into the left atrium, and they had slowly, while doing the in and out of the exchange transfusion, they had introduced a little bit of air slowly. The air had gone into air lock in the left ventricle, and the left ventricle couldn't pump, and the child died. And this was the cause of death. It's iatrogenic, of course. But it's important, this at least gives you some idea what the death was, and you can learn from this. I think all deaths must be learned from. So this is the value of a post-mortem X-ray. I've done hundreds of post-mortem X-rays over my time, and can I say that the lungs and the heart can be looked at, up to a couple of hours, 2-3 hours, 4 hours. The bones, of course, much longer after this. I also do post-mortem echoes and ultrasounds because I find them valuable, especially in very small babies. Okay, I do ultrasound brain, liver, lungs, and everything. Because sometimes you can avoid a post-mortem for parents, and I always don't want to avoid a post-mortem if you can for parents. Just a quick break, and X-rays of animals is also interesting. I'm sure the vet uses all the time. This is a cat with multiple kittens, and that's of course a lizard. Okay, I'm going to the abdomen. Okay, and this is a newborn with a double bubble, and all of you know what a double bubble is about. It's a duodenal atresia, very classical double bubble. Here's another one. This one was done erect. Somebody held the baby up, and you can see the fluid levels there as well on this double bubble. Now, if you look at this X-ray, the bubble is very funny. There's one, there's two, there is a double bubble. Notice the heart is very big as well, and there's some amount of clitora. There is some degree of cardiac failure, and this child actually had Down syndrome. So this actually is a child with Down syndrome, with a congenital heart, which is very common in Down syndrome, with a duodenal atresia and malnutrition. Malnutrition because the bubbles are not in the right place. So an X-ray can tell you quite a bit if you keep looking at it. Okay. That was double bubble. These are more bubbles. That's a duodenal atresia. This is jejunal atresia. Okay. And these are many, many more bubbles. Notice there's not much gas here in the rectum. It's a 5-day-old presental abdominal distension. There are multiple causes for this, but one thing that must be at the back of your mind is Hirschsprung's disease in a term baby. In a preterm baby, you will think of other conditions, but in a term baby, you must think of Hirschsprung's disease. And the only way, of course, of doing this, the surgeon will come and do, of course, a PR and a biopsy, but we could do a contrast study showing the gross dilatation and the agagonic part of this, and your radiology colleagues can help you with that. Okay, so think Hirschsprung's abdominal distension, couple of days of life. But please check the anus. I've seen a number of children with anal atresia also presenting like this. And, I'm sorry, I should have shown some anal atresia pictures, X-rays. I've occasionally had a baby where the checklist has said, check, anus patent, but she come back, no anus. And so some people do checklists, they don't check babies. So always have a good look for a baby, anus. Now here's a preterm neonate. Third day of life, ventilated for respiratory distress syndrome, now suddenly become hypotensive, okay? And with abdominal distension. And for those of us working in pediatrics, this is like, guaranteed diagnosis. The X-ray is just secondary. So abdominal distension, hypotensive, preterm baby, ventilator equals necrotizing enterocolitis, which is a common diagnosis in the NICU. And you can see this line of gas here. Necrotizing enterocolitis shows up in the X-ray as air which is in the wall of the gut. You can see another line there. Okay. Here's a child with necrotizing enteritis. You can see the S. And again, use your handphone camera as a magnifying glass. Why not take a picture and then blow it up and have a good look? And you can see the lines are there. There are track lines inside them. There's air inside the wall of the gut. Okay, here's another good one here on this side. You can see it very clearly here. So this is necrotizing enterocolitis. Bad diagnosis for a child. Okay, here's another one. Very clear to see the necrotizing enterocolitis. This part here may be a little more difficult, but here's it. You sometimes need to do sequential X-rays to pick this up, and sometimes you might even see air. I have a couple of X-rays I need to digitize, which are air in the portal tract, which has leaked out from this NEC. Here's another NEC again showing up the gut. Okay, sometimes part of the gut, sometimes more extensive. So abdominal distension, hypotension, preterm neonate, think NEC, and do an X-ray to help you confirm. And you might need a serial X-ray, maybe 8-12 hourly to pick this up. This is stage 1 NEC, which is very difficult. I don't really know what it means, some distension, some thickening of the gut wall maybe. Again, can look like the Hirschsprung's X-ray we talked about. Notice not much gas down there. But I'm using this X-ray to illustrate something on the next X-ray. Huh? So think about this as stage 1 or maybe Hirschsprung's if there's obstruction. Okay. Now, here's a baby, usually preterm, but can be term baby, who's become hypotensive and with abdominal distension. Okay, notice that the X-ray looks very funny. If you look at this X-ray and compare with the previous one, the gut is very different. These are both distended abdominal X-rays, but they're very different. Look at the gut and look also at the liver. Here it's hard to see the liver there. The liver is there, is solid looking, but here the liver is very well outrun. There seems to be some gas there as well. Notice gas down here in the testis as well. And let me go and do the next one here. Notice there's gas down here in the testis as well. Same condition. Notice now the gut is even better seen, and now we can see air above the diaphragm because this particular baby was held up, and so we could see this. So these are pneumoperitoneum. The source could be a multiple thing. Could be a GIT obstruction with perforation, or it could be an NEC with perforation. But I find if you see this once, you recognize it all the time. It's like a sausage kind of feel of the intestines inside. Notice here, you can see the outside and the inside of the intestines at the same time. Unlike the normal, here's a normal intestines which don't look like that. And always remember, look at the liver, which is much better shown here as well. Okay. And if you do a lateral abdominal X-ray, supine lateral, you will see gas up there, and that will help you with diagnosis. Of course, an ultrasound will also be a quick diagnosis. Okay. Here's an extreme one. The baby is held up in this X-ray. The first time I ever saw this, I think in the early 80s, I thought this was the heart, but it's not. This is the liver. The diaphragms are up there. The heart is being compressed up there. And there's a huge pneumoperitoneum. This needs to be acted on urgently. When I was in areas without a surgeon, I put in a tube. I actually took the smallest chest tube I could find, put in like I would put in, dialysis tube and drain this. Because if you don't drain this, then, the lungs are compressed and you can hardly ventilate this child. But recognize that this is the diaphragm up there and this is a huge air leak. Okay. Some more trapped air there, and that's the liver there. Air again in the testis. I find it always goes down to the testis, which is a good sign of these air leaks that they go down to the testis. Okay. And I've shown this to you earlier of a very subtle air leak, which needs, change in contrast. A badly done X-ray, poorly penetrated, but you can modify X-rays these days. You can also take it to the computer and use the computer software, imaging software to do it, but I think a handphone is a much faster way in the clinical context. I'm coming to the end, as our time is coming to the end as well. And I'd like to show you this X-ray, which is very unusual. I'm going to show one common and one uncommon. This is a very uncommon condition. Well, not really that uncommon, but this child presented with AGE. He was an infant, about 3-4 months. I was working in Kuching. I chose to work there. And one of my housemen did an X-ray for AGE. I was a little bit annoyed with him for doing it for acute gastroenteritis. But then this X-ray came back, and then suddenly we thanked him for doing the X-ray because we saw all this stuff in the abdomen. Okay, took us some time to figure out. Notice that all of it is confined to the abdomen. What is this? This is calcified, it's white. The baby is quite well otherwise, apart from the gastroenteritis. So this baby had an intrauterine perforation. The meconium leaked out. The perforation sealed spontaneously. The child continued to be well, and now the meconium is calcified. Important to know for the parents because this child will have gut adhesion and may get problems later, might get intestinal obstruction from gut adhesions. Okay, there's no point going in right now until run the problem. But very interesting X-ray from one of our young house officers. Here's another X-ray, you know, showing a newborn baby with respiratory distress at birth. This is a fairly common, when I say fairly common for a pediatrician, I think we would see 4 to 6 of this a year in an average center, and you can see that the X-ray looks very funny. The child, of course, been intubated. There's the X-ray is rotated, but still you can see a shift. The heart is over here. This lung is collapsed a little bit, compressed a little bit, but there's some funny thing here on the left side. This kind of bubbly kind of appearance here. Okay, and here's another one, more classical. You can see this bubbly appearance, and the heart push, and sometimes the lung on the other side compress. And so this is congenital diaphragmatic hernia, a major emergency with neonates. Okay, and can present just like that, present respiratory embarrassment. The X-ray tells you diagnosis immediately. But this one maybe miss. That's why I showed this first, because it doesn't look so clear. This one is much clearer. All the gut is up there, and the baby is fine until he starts breathing, and then the gut fills with air, expands, and pushes the lung. One of the first things you should do is put an nasogastric tube in and try and suck out some air with a syringe, and then make sure nobody caps an NG tube, leave it free flowing. Second thing you might have to do is intubate the child, depending on, you know, the degree of respiratory embarrassment, and then, you know, stabilize the child for surgery. Okay. I like this saying, it's Rottingen's law. The length of radiologist report is inversely proportional to the certainty of his diagnosis. Here's her diagnosis. So I think quite often radiologists give you a very lengthy report. They probably don't know what they're seeing. You know, I value radiologists greatly. They taught me quite a bit. And I find always going and sitting with radiologists and doing an ultrasound, or sitting with them and watching X-rays is a marvelous way to learn, a great elective for any medical student, or even someone right now who's waiting to join. If you could join a radiologist and learn, it'd be a great thing to do. I've got some more X-rays, but let's stop here for now. Okay.
Okay, thank you so much. I went through your X-rays with my jaw dropping, my heart dropping. It's quite painful to see actually. Oh, sorry. Okay, I need to get you back. I'm so sorry. Hold on. Huh? Where are you now?
I'm here.
Wait, I can't find you. Where are you?
I'm here. I'm speaking right now. Can you see me now?
No, the thing is, I put myself as, okay, remove P. Okay, thank you. Okay. So I'm trying to what Joanne said, and I can't put our pictures side by side, so I'm
Not to
not.
worry. Not to
Yeah.
worry.
So
Yes.
okay. So we will take questions now. Yeah, please feel free to either ask questions by unmuting yourself, or if you are too shy, um, you can actually put in the chat, or on the Facebook. You can also ask us questions on the comments. Let me see. Let me go to the Facebook now. Okay, there are 6 comments on the Facebook.
Mm-hmm.
No, most of the comments are just saying hi only. Anyway, it was a really, really.
There's a comment. There's a question in the chat group. Is there a particular feature to differentiate pneumonia, RDS, MAS, heart failure in a chest X-ray?
Okay.
That's a very, very Farhana is a very long question to answer. I believe that Farhana, the key is to know some pediatric conditions. It means, as I said, you know, if you know your conditions, then you know what to anticipate on the chest X-ray. But as I showed you, meconium aspiration is a patchy thing. You know, some parts hyperinflation, some parts consolidation. RDS will be ground glass. That means it's uniform. Congenital pneumonia RDS, I am not able to differentiate. I need a story. You know, as I said, even some term babies might develop RDS. But generally, if I saw a term child with a ground glass appearance, a uniform spread pneumonia, you know, fine particles all over the place, then I would consider that to be probably a pneumonia more likely than RDS. If I saw that in a preterm baby, then I'll probably think it's more RDS. Okay. Heart failure, I think the cardiologist here could tell us, but heart failure, as I said, in children usually is left ventricular failure, and then you might see some increased lung markings coming out from the hilum upwards and diffuse. But sometimes it can be very severe that the whole lung, like one of the X-rays I showed you with the globular, with a very big heart, the whole lung looks very whitish at time. I think that's probably what I can tell you. But the heart size will be very important in heart failure. The heart size needs to be big in cardiac failure.
I think it's very important to actually also realize that we do not just want to treat an X-ray, we take the whole clinical pictures into consideration.
Yes.
That is a very important point, especially when you are. Um, okay, I don't know who is this bear. This
That's
oh, this is yours. This
Yeah.
is,
Nicole
okay,
has put a question here. Nicole
yeah, that's
says,
right.
may I know how you differentiate gut perforation and normal impacted stool on abdominal X-ray? Okay. Nicole, in impacted stool, you seldom would get GIT obstruction. You can if it's very, very severe. I've seen some children, especially children who are significantly disabled with quadriplegic cerebral palsy, you've got enormous impacted stool, and then they get a lot of stasis. But usually, gut perforation is a gut perforation, which means there's an air leak. If you do erect film, you will see air in the diaphragm, okay, for sure, all right, which you won't see in the impacted stool. So that's a useful differentiator. Impacted stool usually might see some stasis, but not a perforation.
But correct me if I'm wrong. Of course, a patient with a perforated gut would be very, very much more ill than a
Thank
patient
you,
with
Betty. That's a very important
yeah.
thing as well. Yeah, would be
Blood vessels will be
hypotensive as well.
bunched, patients will be dehydrated.
Yes, correct. One Dizola, if I'm pronouncing the name rightly, one said, sorry to ask, what happened when you found out the cause of pediatrics to iatrogenic post-mortem death? Now, one, I think, I've seen lots of mistakes made over time. I've made my own mistakes. Anybody who says they have not made mistakes is God. I wouldn't tolerate any pengara or specialist who, criticizes anybody young who makes mistakes. There are two kinds of mistakes in life that I think about: intentional and unintentional mistakes. You know something is wrong, and then you go and do it. That I think we won't accept. I remember a young doctor who the nurse told him, hey, I'm worried about this child. The ETT is too deep. We need to do something. And he left because it's 5 o'clock. That kind of mistake we will not tolerate. But many of the mistakes we make are unintentional, and they end up with some amount of damage. I've done a couple of studies in this, and I like to tell you that, it's not uncommon. I would think from US studies, I think, in just medication prescriptions, 10 to 15% of all prescriptions have got a medication error. In one study I did in Malaysia in primary care, 25% of all prescriptions had a medication, 25% of prescriptions in primary care had a medication error of some sort, dosaging, duration, frequency, name, or something like that, or illegibility. So I think that we are learning, and if you can learn from your mistakes, that's what we hope for you. So this particular individual who, accidentally caused that death, we supported the person. Okay, we as a department accept the mortality. We don't accept it as an individual there. There's one from Dama who's saying, hi, myocarditis is common in pediatric and could X-rays illustrate the diagnosis? No, myocarditis is thankfully not common unless you have an outbreak. We do have outbreaks of hand, foot, and mouth disease in the past. EV71, we do not know why those outbreaks recently have diminished. Thank God they do. At one point, we saw a large number of dilated cardiomyopathy deaths. I even went to Sarawak to help out. There were deaths. I remember in Taiwan, there are 90 deaths of children in a short period of time. So it comes episodically. Endemically, we have, maybe in the country, 3 or 4 at a time. The X-ray may help, but not always is the heart dilated. I think the echo is far more useful, and I recommend that all young doctors should be able to do echo. Just put the probe on the heart, and you can see the contractility is no good. The heart is just beating like, I don't know, it's my hand like that. It's very, very shallow, quick beat, and the heart rate is usually 100, 120, something like that. That is a better diagnostic feature. Okay. Nicole
has a question.
Yes. Earlier, when talking about child with calluses, you mentioned a situation where you definitely do a full body X-ray in children. Yes. Nicole, I would do a full body X-ray for any child brought in date. It's one of my things. So a child brought in date for which a diagnosis is unknown. which means, we don't have a prior illness in this child. It's not a child known with a malignancy or something like that. A child just brought in dead to casualty. I would do a full body X-ray. It's not difficult to do. My radiology colleagues have always been supportive. And over time, I have seen a considerable number of conditions on the X-rays. It's a useful diagnosis for looking for fractures as well. Can I say for rib fractures, I always ask my radiologist colleagues to look at. They are subtle rib fractures. They're not the easiest to see. Fractures in other bones are easier.
Okay, before we go to Asma's question, we will just attend to the Facebook Live questions, seeing
Sure.
us whether this is recorded so he can watch it back. Yes, it is. So we will put it in YouTube. You can watch it at your own time. Amalina asked, up to what age do we use posterior ribs to measure chest expansion in chest X-ray?
I
And
think
why exactly
ribs,
we
you can use
change
the
and
anterior or posterior ribs at
this
whatever age you like. I tend to use the posterior ribs to measure. Some people might use the anterior ribs. I think it's your preference. Even in adults, Betty, what do you do in adults?
Oh, I read the X-ray report by the radiologist.
Good one, Betty. I think even physicians will just look at the X-ray and eyeball. I think when you come to a certain age, you just eyeball the X-ray because you know
Right.
the inspiration is good, huh?
I can't
Okay.
remember when the last time I counted ribs. Okay, she asked when exactly do we change to using the anterior rib? So we can always use the posterior.
You can always use posterior, or you can use the anterior, your comfort. I find anterior ribs are harder to see. Uh, you know, I think I probably will not use posterior ribs if it's a very poorly penetrated film because I may not see them so clearly. Okay.
Okay, Yvonne asked, may she ask how to identify thickened bowel wall on abdominal X-ray, and it may suggest NEC feature. Thank you.
Yeah, Nicole, the better feature for NEC is the air in the lumen, in the wall cavity. Yeah? That is a better diagnosis for NEC. Bowel wall thickening, I think you need to. I suggest what you do. Some of you got questions of this. I suggest you just do a Google search. Look for bowel wall, normal abdominal X-rays, and then look for thickened bowel wall. Then you can see the difference if you look at number. I find internet is a phenomenal teaching aid if you're willing to search for images. That's the best thing I can suggest to you. Huh? Okay.
Okay,
That's a
Asma,
question.
ask,
Asma, yes, go ahead.
yes. Maybe you'd like to read the question.
Is there any specific criteria when to insert a chest tube, when to treat conservatively for pneumonia? Again, come back to Betty's comment earlier, it's a clinical decision. Uh, if the child is
இல்ல
stable,
உள்ள துடைக்கும் போது அது பாய்ச்சி துடைச்சிருங்கன்னு சொன்னேன்.
if the child is stable and the pneumonia and the pneumothorax looks small, I will sit on it. If the child is stable and the pneumothorax looks huge, I will put a chest tube in. If the child is unstable, I will put a chest tube in, no matter what size pneumothorax, I think. As long as I saw pneumothorax there. So unstable child pneumothorax, I put in. Stable child, small, I wouldn't put in. Sizable pneumothorax, I think I will put it in because he's going to become unstable later.
Okay, Sita asked, hi, Dato Dr. Amar, regarding
Yes, Amar, fine, yeah.
so that's $50 fine there. Regarding spiral fracture, I think she's meant spiral fracture at unusual bones like femur. Must one explore for NAI, despite no history or other bruises suggesting it?
Yeah. Yes, Rifa, I think. And what we will do at that time is do a skeletal survey. And maybe I should have put that in as well. What's a skeletal survey? We do limited X-rays of the child looking for other fractures. We usually do a lateral of the skull. We do an AP of the chest and try and include the upper limbs. And then we do the both lower limbs. And then we get a radiologist to read this formally when we suspect. So when you see a spiral X-ray, a spiral fracture, especially with the femur, definitely we would think child abuse. Then looking at all the X-rays, of course, examining the baby carefully. If the child is old enough, by the time it's 3 or 4, definitely can start telling us things. By 5, all children can tell us things. We would definitely interview the children without the parents around and see. We definitely will examine all the other children at home. All these things are clinical things that we will do and then try and reach a decision. And we might make a decision saying, there's some suspicion here, we're not sure, in which case we will do a follow-up of this child, put on an at-risk register with welfare department, or we might see another fracture somewhere else or a lesion, and then that will confirm a diagnosis of child abuse. Very
Very
common.
so painful. Okay, I think we have had a very good session. We have done in about an hour and a bit, and we will stop here. Thank you so much, Amma. I
Mhm.
think we will. I've seen a list of your lectures that you may provide, so I'm call you back. I'm going to have a look again at our chat, and join us. We are not having any more session for this year because it's going to be Christmas and festive season soon.
Mhm.
So I would like to take this opportunity to wish you all a Merry Christmas and a very good year ahead. And we start again next year. I have some webinars sessions really already scheduled. I have one on diabetic emergency in January,
Mm.
and then one on autism and how to actually start yourself working with autistic kids. I think Dato Dr Lai is going to give us on that. And then after that, we hope to actually make smaller groups for teaching session on how to deal with autistic kids, and maybe train some of you because you know maybe you'll be interested in dealing with them. Okay, and then yeah, see you guys. Have a nice weekend ahead. Thanks, Amma, again. Say bye to
Thank
your
you. Take care, everyone. Blessed Christmas
bye.
and New Year. Mhm.
Yes, Happy New Year.